Hello everyone. Today the topic we are going to discuss on is Cor Pulmonale. So you should know what do you understand by Cor Pulmonale, what are the clinical features, the etiology, treatment, what you have to do and all. Okay, so this is about the Cor Pulmonale. So what is Cor Pulmonale? Cor Pulmonale, it means right-sided heart failure. Now here you need to remember one thing very clearly, that last time I think when I was talking to you about heart failure, I had told you that mostly there are, the cause of right heart failure is due to left heart failure. Initially what happens, there is a volume overload in the left heart, in the left ventricle. There is back pressure from the left ventricle to left atrium, and from the left atrium to the pulmonary circulation, and then from the pulmonary circulation to the pulmonary artery, and gradually this pressure is transmitted backwards. Okay, so and then there is a pressure overload, okay, so in the right ventricle, and ultimately there is right-sided heart failure. But that time I had also told you that this is not the only cause of right-sided heart failure. What is not the only cause of right-sided heart failure? That left-sided heart failure is not the only cause of right-sided heart failure. There are also many other causes of right-sided heart failure. So these other causes, that is mainly what comes under the cor pulmonale. Remember, this is very, very important. Right-sided heart failure without left-sided heart failure, without left-sided heart disease is what is called as cor pulmonale. So in Viva, this is a very important question which is asked to you. They often ask you, what is cor pulmonale? And most of you say it is right-sided heart failure. So then the next question which is asked to you, the most common cause of right-sided heart failure is due to left-sided disease or left-sided heart failure. So is that included under cor pulmonale? So you say no. Okay, the right-sided heart failure, which is due to the left-sided heart failure, or which is, if along with the right-sided heart failure, there is some left-sided heart disease also, that is not included under cor pulmonale. This is mainly due to in the cor pulmonale, that is your right-sided heart failure, which is mainly due to the diseases in the lungs. Okay, so diseases in the pulmonary circulation. If there are diseases in the lungs, if there are any diseases in the pulmonary circulation, you must be knowing from the right ventricle, this is your pulmonary artery. Okay, the blood from the right atrium first from the vena cava, the blood enters into the right atrium, from right atrium to right ventricle, from right ventricle to pulmonary artery. Okay, pulmonary artery to your lungs. Okay, so and from the lungs via the pulmonary veins, it is going to enter the left atrium to left ventricle, and then through the aorta, it is going to be pumped to the rest portion of our body. Now, if there is any, we'll study what are the different pathological conditions which can happen in the lungs, due to which there can occur right ventricular failure. So this right-sided heart failure, which is due to some diseases or pathology in the lungs, in the pulmonary circulation, or in the thorax, those things are included under the cor pulmonale. So this thing should be very clear. Cor pulmonale is right-sided heart failure, mainly due to diseases in lungs, pulmonary circulation, or thorax. It is not due to the left-sided heart failure. Right? So this is a very important thing which you need to know here. And so what is the most common cause of this right-sided cor pulmonale? Mainly pulmonary hypertension. The pressure inside these pulmonary arteries, they increase. I'll tell you the different, causes due to which the pressure inside the pulmonary arteries can increase. What we say it as pulmonary hypertension. So obviously, if the pressure inside the pulmonary arteries will increase, the left ventricle has to push the blood into the pulmonary artery with a greater force. Okay, so there will be a pressure overload in the right ventricle. This can lead to right ventricular hypertrophy. So we will just go through those. So mainly remember that it is mainly due to the pulmonary hypertension, and pulmonary hypertension in cor pulmonale is defined as pulmonary pressure, arterial pressure in the pulmonary arteries more than 25 millimeters of mercury. Okay, pulmonary arterial pressure above 25 millimeters of mercury with the pulmonary capillary wedge pressure, and the left atrial pressure, or the left atrial pressure or the left ventricular end diastolic pressure, that is less than 15 millimeters of mercury. So this is the main thing you remember. Pulmonary hypertension in this cor pulmonale, we define it as when the pulmonary pressure in the pulmonary arteries is more than 25 millimeters of mercury. right? So next, what we need to discuss is that we'll discuss about the subtypes of cor pulmonale. Now, cor pulmonale, it can be either acute or it can be chronic. So what is acute cor pulmonale? Acute cor pulmonale, when there is sudden increase in the right ventricular pressure, right? I just told you, suppose like if the pressure inside the pulmonary arteries increase, the right ventricle has to push the blood, more forcefully. This will lead to a pressure overload. So this increase in the right ventricular pressure, this can take place gradually or it can take place all of a sudden. So if there is a sudden increase in the right ventricular pressure, then it will cause acute cor pulmonale. So what can be the cause of a sudden increase in the right ventricular pressure? What can happen? What do you think is a sudden something will happen in the pulmonary circulation that will cause a sudden rise of pressure in the right ventricle? Yes, that can be a pulmonary embolism. Okay, there can be a pulmonary embolus in the pulmonary arteries. Okay, or it can be ARDS, acute respiratory distress syndrome. Okay, so these are these embolus, pulmonary embolus, okay, embolism in the pulmonary arteries, or ARDS, acute respiratory distress syndrome. So these can lead to, after a massive pulmonary, embolism, mainly that is one of the main causes of acute cor pulmonale. Okay, because of this massive pulmonary embolism, there will be acute pulmonary hypertension, and that will result in the right because it will result in the right ventricular dilatation. In these acute cases, there will be right ventricular dilatation. Obviously, in acute cases, there won't be hypertrophy. Okay, so in chronic, if it is a chronic case, then over the time there will be hypertrophy of the right ventricle. But in acute, there is no hypertrophy because it's acute, sudden onset. There is mainly dilatation of the right ventricle. Okay, and what is chronic cor pulmonale? Chronic cor pulmonale, obviously, it takes place gradually. So this is, this can be further classified by hypoxic or vascular obliterance. Like, many times due to hypoxia, okay, so there occurs the, the pulmonary vasculature, there occurs constriction in the pulmonary arteries. Okay, so because of this constriction, the heart has to push blood with a greater force into the pulmonary arteries. Okay, so, so this is one of the main reasons. Okay, so what do you think is the most, one is I told you hypoxia, another is vascular obliterance. I'll tell you what is this vascular obliterance and what the most common causes of these two. So hypoxia means the pulmonary circulation, there is less, oxygen, less amount of oxygen is reaching the pulmonary circulation. So what is the most common cause of hypoxia? COPD, chronic obstructive pulmonary disease. Okay, chronic obstructive pulmonary disease, you must be knowing about it, that it mainly comprises of two things, either bronchitis or emphysema. Patients usually present with bronchitis or emphysema. Okay, so in these patients, they often develop hypoxia. So there's development of hypoxia in this pulmonary circulation, and this leads to increase, there occurs the vascular constriction, the pulmonary vessels, they constrict, and therefore the pressure in the pulmonary arteries increase, and the right ventricle has to force or push the blood with a greater pressure. This results in a right ventricular hypertrophy over time, and it causes chronic cor pulmonale. This is one thing. And talking about vascular obliterance, from the name only you can understand any disease, any pathology which is causing obliteration in these vascular bed. Okay, so any inflammation, any swelling, any thrombus, okay, so which is obliterating this vascular tree, right? So acute and chronic. Next, let us see what are the clinical features, how the patient is going to present to you. Let us talk about the acute cor pulmonale, the features of acute cor pulmonale. So as I told you that the most common cause of acute cor pulmonale is your massive pulmonary embolism. There is massive pulmonary embolism. So if you all have seen any patient of massive pulmonary, since it's an emergency, okay, if you all have seen any patient of massive pulmonary embolism in the ER, in the emergency, so that is, you typically see the patient will come to you with signs, there'll be acute dyspnea, there'll be acute breathlessness, and sometimes there can also be hemoptysis. Okay, and syncope, the patient will be breathing fast, tachypnea, tachycardia, BP gets low. So you will all find all the features of pulmonary embolism. First, let us see what are the features of pulmonary embolism we can find in the patient, and if this pulmonary embolism has also caused, acute right heart failure, what are the features of acute right heart failure? So we'll discuss about pulmonary embolism separately in the respiratory chapter. Just know a few basic things what the patient mainly presents with. The patient will come to you with acute dyspnea. Okay, so hemoptysis. What is the meaning of hemoptysis? It means coughing up blood. Okay, so the patient coughs up blood. So there is acute dyspnea, hemoptysis, and there is sometimes syncope, cardiac arrest. Okay, the BP there is goes low. There is hypotension. Okay, so there is tachypnea. So these are the main symptoms of signs related to not symptoms, signs related to pulmonary embolism. Okay, and signs related to acute right heart failure. So here there is mainly when you see the JVP, you will find a raised JVP, jugular venous pulse. Okay, so that is raised. Parasternal heave. What is parasternal heave? If you have attended your practical classes, you must be knowing what is parasternal heave. In parasternal heave, what you do is that. So what you do in this parasternal heave, how will you see that whether there is parasternal heave or not? So you place the heel of the hand over the left parasternal region. Okay, so over the left parasternal region, you place the heel of your hand on the left parasternal region. And if there is a heave, then you will find that the heel of your hand is lifted off the chest with each systole. Okay, so with each systole, you will feel a lift, you will feel a thrust. Okay, so on the heel of your hand, that is your parasternal heave. And you can also find your third heart sound, S3 gallop, third heart sound. That is also if you auscultate the chest, you can hear the S3. So these are the features of acute right heart failure, and these are the clinical features of pulmonary embolism, right? So next, let us see about the chronic cor pulmonale. So what are one of the main causes of chronic cor pulmonale? Just now I told you that the main causes of chronic cor pulmonale is COPD, chronic obstructive pulmonary disease, and also chronic bronchial asthma. But remember, chronic bronchial asthma is a very uncommon cause of of this acute chronic cor pulmonale. Mainly it's COPD or pulmonary tuberculosis, any interstitial lung disease, high altitude. If you're if those people who are staying in the high altitude, okay, so high altitude dwelling for a long period when they're staying in the high altitudes, cystic fibrosis, and pleural fibrosis. Okay, so ILD, and you have got cystic fibrosis, pleural fibrosis. So these are the different causes related to the lungs which can lead to cor pulmonale. So COPD, so COPD, it's a chronic obstructive pulmonary disease. There is airway obstruction. Okay, so there is improper airway exchange, as a result of which there is hypoxia, and this hypoxia causes pulmonary vessels vasoconstriction. Now the thing, yes, I just forgot to tell you in the early things, that is, you must be thinking that hypoxia, that causes vasodilation, right? So why is it causing vasoconstriction here? Remember one thing very clearly. Hypoxia causes vasodilation in other vascular beds. It is only in the pulmonary vascular bed it causes vasoconstriction. Okay, that is why it's called as hypoxic pulmonary vasoconstriction. The hypoxia causes vasoconstriction only in the pulmonary bed, in the pulmonary arteries. Okay, in the pulmonary arteries. And talking about the other diseases, like cystic fibrosis. Cystic fibrosis is the inherited disease, and it is usually diagnosed in childhood only. Here, the airways, they are inflamed, and these these children, these people who are having this disease, cystic fibrosis, they secrete a lot of sticky mucus which blocks the airways. So again, this also causes hypoxia, and there is inflammation, hypoxia, pleural fibrosis, there is inflammation, hypoxia, ILD, there is lung damage to the tissues of the lungs. So all these things, it leads to the chronic cor pulmonale. So these are things which is occurring in the lungs. Okay, and diseases of the pulmonary circulation. Yes, diseases of the pulmonary circulation, like again I told you, if the patient is having recurrent pulmonary thromboembolism, So it's acute pulmonary embolism, it will cause acute heart failure. Recurrent, again and again, the patient is having thromboembolism, primary pulmonary hypertension, collagen vascular diseases. Collagen vascular diseases, they cause damage to the lungs. Okay, or your chronic liver disease that can also cause cor pulmonale. Okay, then come to the diseases of thorax. Thorax, there are different diseases of thorax also, like where the patient is not able to breathe properly. Okay, there is proper air exchange is not taking place, which leads to hypoxia. Like you have got your kyphoscoliosis. Now, what do you understand by? So why thorax? Why does kyphoscoliosis cause why does kyphoscoliosis cause cor pulmonale? Actually, in kyphoscoliosis, there is an abnormal curvature of the spine. Okay, so both, from side to side, there is kyphosis and there is scoliosis. Both the things are there. There is side to side abnormal curvature of the spine as well as back to front. So both the, both the planes, there is abnormal curvature of the spine. And what happens due to this, because of this curvature, abnormal curvature, there occurs the extrapulmonary constriction or restriction to the lungs. Okay, there is extrapulmonary restriction to the lungs, and this extrapulmonary restriction, it gives rise to the different impairment of the pulmonary functions. So you have got kyphoscoliosis, different neuromuscular diseases. Okay, so they also cause, the proper air exchange doesn't take place. Obesity, sleep apnea syndrome. Some people in sleep now, there is suddenly there is apnea occurs during sleep. So sleep apnea syndrome. So all these things, they can lead to impairment in the, it can lead to the chronic cor pulmonale, right? So this is very important. And out of all these things, you should remember COPD is the most important cause of chronic cor pulmonale. So COPD, as I told you, it includes two things. What are the two things I told you? It is bronchitis and emphysema. Okay, so just you should remember one thing. Sometimes it is asked in Viva, or just for your knowledge in the different entrance examinations also it is asked. These people who who get bronchitis, they are called as blue bloaters. Often this term is asked. What do you understand? Who are called blue bloaters and pink bloaters? Bronchitis patients, they are called as blue bloaters, and the patients with emphysema who develop chronic cor pulmonale later, they are called as pink bloaters. Emphysema. I'll just show you a pic of this, of this blue bloaters and pink bloaters. Blue bloaters and pink bloaters. Just let me share a screen with you all. Share this PowerPoint. Okay, cor pulmonale. Slideshow. Yes. Yes, look at this blue bloater and pink puffer. They are also called, sorry, I'm so sorry, they're not a pink bloater. I think I told pink bloater. No, it's not pink bloater, it's pink puffer. Okay, blue bloater and pink puffer. Blue bloater, these patients, they are mainly the bronchitis, chronic bronchitis patients. They are called as blue bloaters, and emphysema patients are called as the pink puffer. These bronchitis patients, mainly they produce a lot of cough. How will you mainly differentiate? Like just by looking the symptoms, from the symptoms, how can you differentiate whether the patient has got bronchitis or emphysema? In bronchitis, the patient produces a lot of cough. Okay, a purulent sputum. The patient coughs a lot, and there is a lot of purulent sputum. Sometimes they also cough out blood, and they are called as blue bloaters because they often develop cyanosis. Okay, the blue discoloration of the skin. They develop cyanosis due to hypoxia, and if these patients develop right heart failure, then there occurs peripheral edema, and when you auscultate the chest, you will find crackles, wheezes. Okay, and these patients are usually obese, right? And look at these pink puffers, that is the patients of emphysema. These patients, there is very minimal cough. Okay, and like these patients, the blue bloaters who are there, the chronic bronchitis, they cough a lot. Okay, so they have a chronic cough, and they usually, they have a lot, they produce a lot of sputum, like purulent sputum. But the patients, the emphysema patients, they have minimal cough. They have dyspnea, they have minimal cough, and they have got pursed lip breathing, pursed lip breathing. And the skin, they have pink skin. That is why what they are called as the pink puffers. Okay, and they are usually they're thin built. Like usually in blue bloaters, these people are obese, whereas these people, they are thin built people. And these patients, they have also got dyspnea, tachypnea, decreased breath sounds. Like here, when usually these patients, they have a silent chest, decreased breath sounds, right? So pink puffers, blue bloaters is chronic bronchitis patient, pink puffers are the emphysema patients, right? So this thing you needed to know. Sometimes it is and all. Okay, it's not pink bloater, it's pink puffer. Right. So next, let us see the pathogenesis. Okay. So what is occurring in hypoxia? This already I've told you, but still I'll just tell you once more. So what is happening in these patients? Why are they developing this right heart failure is that? So first, these patients are having some chronic lung disease. Actually, remember one thing, just now I told you which all patients you will classify under cor pulmonale. Those patients who develop the right heart failure due to diseases in lungs or in the pulmonary circulation or the thorax, and not due to the left ventricular failure. Those patients who have got right heart failure, and because of right heart failure, they're developing those patients who have got left heart failure, and because of left heart failure they are developing right heart failure, such patients are not to be included under this category. Okay. And one more question, sometimes if you answer, like one more criteria is that someone might ask you, what about those people who have got congenital heart diseases? Congenital heart diseases, are we supposed to include them under cor pulmonale? No. Congenital heart disease patients are also not to be included under cor pulmonale. Actually, cor pulmonale, this word is a Latin word. This Latin word, it mainly means pulmonary heart, mainly the right heart failure, which is occurring due to the pulmonary causes. Either there is some disturbance, diseases in the pulmonary circulation or in the lungs. So those causes, which is due to which they develops right heart failure, those things come under the cor pulmonale. Okay, so let us look at the pathogenesis. First, the patient has developed a chronic lung disease. Let us take the most common example, that is just COPD. So because of COPD, there is improper air exchange that has led to hypoxia. Because of hypoxia, there has occurred pulmonary vasoconstriction. The blood vessels have constricted, and that has caused pulmonary hypertension. Okay, and right. So apart from causing hypoxia, COPD, that also causes acidosis, and it also increases the carbon dioxide concentration in the blood. Also, it can also cause hypercapnia, right? And there is also reduction in the pulmonary vascular bed. Reduction in the pulmonary vascular bed. So because of all these things, there has occurred pulmonary hypertension. Now, when there is pulmonary hypertension, you can understand that the pressure inside the pulmonary blood vessels will increase. Who is pumping blood inside the pulmonary artery? The right ventricle. Now the right ventricle has to push more. It has to, more pressure has to be exerted by the right ventricle to push the blood into the pulmonary artery. Therefore, there will be the hypertrophy and dilation of the right ventricle. So hypertrophy in chronic cases and dilation in the acute cases of the right ventricle, and ultimately there is going to be right ventricular failure. Okay, so this is the pathogenesis of a cor pulmonale. Pathogenesis mainly of the chronic cor pulmonale, right? So next, let us see what are the clinical features. Clinical features of chronic cor pulmonale. Acute cor pulmonale, I have already discussed with you the clinical features of acute cor pulmonale. What were the clinical features of acute cor pulmonale which I discussed? I told you, you have to say about the clinical features of pulmonary embolism and the clinical features of acute cor pulmonale. Now talking about the clinical features of chronic cor pulmonale. So these patients, they have as such, there is no specific symptom of chronic cor pulmonale, but these features often overlap with that of the COPD. So these patients, they develop a dry cough, okay, and there is dyspnea, which is not relieved even by sitting up. So as I had told you, I had discussed to you about the cardiogenic pulmonary edema. Remember earlier I had discussed with you about the left-sided heart failure. There I had told you key patients, they usually get dyspnea on lying down or in the supine position, and when they sit up, okay, so when they stand up or when they sit up, so at that position, there is the dyspnea which is there that gets relieved. But remember, in these cases, the dyspnea that doesn't get relieved even by sitting up. And because this dyspnea is mainly due to this pulmonary hypertension. Okay, and when the patient exercises, then there is rapid decline of the oxygen levels in the arteries. Okay, so there is rapid decline of arterial oxygenation on exercise. Decline of the arterial oxygenation on exercise. Okay, on exercise. Okay, so then what else? The patient, gets dry cough, there is fatigue, and usually there is what happens is that the pulmonary artery, there is dilation of the root of the pulmonary artery, because of which the patient can get chest pain, anterior chest pain. And whenever the patient is exercising, exercise induced peripheral cyanosis. Okay, so whenever the patient is exercising, they can develop peripheral cyanosis, and there can be swelling on feet. So this is the symptoms with which the patient will present to you. These are not the signs, symptoms is what the patient presents to us, and signs are what we are going to see in the patient. Okay. So these are the symptoms with which the patient is going to present to you. So what will the patient come and say you? That the patient is having difficulty in breathing. When you ask the patient that when you sit up, when you're sitting up, okay, so is your breathlessness getting relieved? He's saying no. And whenever the patient is exercising, there is, there is bluish discoloration of his skin, and he's having difficulty in breathing, exercise-induced peripheral cyanosis. There is swelling in his feet, and there is dry cough, fatigue. Okay, so these are the symptoms which the patient is going to present with. And what are you going to examine in the patient? What are the signs? You will see that there is pedal edema. Okay, there is swelling in his feet. And when you look at the JVP, you will find that the patient has got a raised JVP with very prominent A waves. I've discussed JVP details. You can go and refer to that. What do you understand by A waves, C wave, V waves? So there, these patients, they have got prominent A waves. And when you place your heel of your hand, okay, so in the left parasternal region, you can find a heave. Okay, so you can find a right ventricular heave. So right parasternal heave or right ventricular heave that can be felt when you place your heel of the hand on the left parasternal region. Okay, and what else? When you auscultate the chest, you can find a very loud P2. Loud, this also I've discussed when I was talking about the heart sounds, about loud A2, loud P2. I told you, loud A2 is in systemic hypertension, loud P2 is in pulmonary hypertension. Right? And you can also find a fourth heart sound, right-sided fourth heart sound, and pulmonary ejection sound. About murmurs, I shall take a separate class about murmurs, different types of murmurs, which murmur you can hear in which disease, which pathological condition. So here you just remember, here you can hear a pulmonary ejection sound. There is ejection in the pulmonary area. When you auscultate the pulmonary area, you can find a ejection systolic murmur. Okay, so you can find ejection. I'll just tell you about when we will discuss about murmurs. We will discuss about everything. I'll tell you what is ejection systolic murmur. Okay, and all those things. And those patients who have got a very high pulmonary arterial pressure. Okay, so when the pulmonary arterial pressure is very high, that time there occurs tricuspid regurgitation, and this tricuspid regurgitation that leads to a pansystolic murmur. Pansystolic murmur of tricuspid regurgitation. This you can hear only when the pressure in the pulmonary arteries is very high. Okay, so these are some of the signs which you are going to see in the patient who has come to you, and you can see that the patient is breathing fast. There is tachypnea even on mild exertion. So these are the different things which you can see in this patient, right? And overt right heart failure. So overall, when you, certain signs which you see in the patient, which indicates that the patient has got an overt right heart failure. What are the features of overt right heart failure? First, there is increasing peripheral edema. Okay, so as I told you, when you look at the peripheral, it will mainly the pedal edema. Okay, so there is an increased peripheral edema. And I told you there is the raised jugular JVP. Why there is a raised JVP? If you do you remember the class on JVP which I had told you? What is happening here? The pressure in the pulmonary arteries has increased, right? So the right ventricle has to push blood, more forcefully. And sometimes what happens, the right ventricle is not able to push all of the blood into the pulmonary arteries also, right? So there is hypertrophy and there is dilation. Now, since the right ventricle is not able to empty properly, so there is back pressure from the right ventricle to the right atrium, and from the right atrium, this pressure, increased pressure in the right atrium, that will be reflected in your JVP. Okay, therefore there will be raised JVP. And when there is back pressure in this right atrium, so the emptying of the blood from the veins into the right atrium, that is also not taking place properly. Okay, understood? From the right ventricle, blood is not getting properly emptied in the pulmonary artery. So similarly, because of this back pressure in the right atrium, so the blood from the veins, that is also not getting properly emptied into the right atrium. So because of this thing, what is occurring is that there occurs congestion. Okay, so there is going to occur peripheral congestion. Peripheral congestion, like there'll be enlargement, of the liver. Okay, so there will be a tender hepatomegaly. Okay, so the liver, there will be, enlargement of the liver. There will be hepatomegaly and tender hepatomegaly, and there will be cardiac enlargement, and there will be raised JVP. Okay, so these are and there'll also be the right, as I told you, S3, right ventricular heart sound, gallop rhythm. Okay, so these things you are going to find very important. Tender hepatomegaly. Tender hepatomegaly is a very important, sign which you can find in the patients of right heart failure. Often if you go to the wards, you see a patient of hepatomegaly. So you just palpate and you see whether it's tender or not. Okay, if it's tender, it is very much in favor of right heart failure. So again, as I told you, that additional features you can find in patients of chronic bronchitis. The patient, he'll be having a chronic cough, lot of sputum production. Okay, and the patients of emphysema, you can find that there is with little bit of exercise, the patient is having marked dyspnea. Right. And in the patients of emphysema, as I told you, bronchitis and emphysema, bronchitis, they cough a lot and they produce a lot of purulent sputum. But in patients of emphysema, yes, they have dyspnea, but they don't cough much. There is very minimal cough and they produce, and there is less sputum production in these patients, in the patients of emphysema. So those patients, accordingly, you can understand whether they have got bronchitis or emphysema. Okay, so next let us look at the investigation. This is what the patient has presented to you with. You saw the signs in the patient. Next, obviously, we have to go for investigations to confirm. Okay, so what we are suspecting, whether it is correct or not. So first we shall go for the chest radiography, chest X-ray. Let us look. Yes, this is a chest X-ray of a patient having. Yes. Look at this chest X-ray. What can you see? What is this arrow pointing at? What is this? What is this arrow pointing at? This is a enlarged. This is actually showing the enlarged main pulmonary artery. Here, if you see a normal X-ray, you just see. Yes, this is a normal X-ray. Look at a normal X-ray. So here you can't see, the pulmonary artery that is not prominent here. Okay, so but here look at this one. Here is your pulmonary artery. Can you see there is an enlarged main and the hilar, mainly these in the hilum, the main pulmonary artery and the hilar pulmonary arteries. So there is a enlarged main and the hilar pulmonary arterial shadows. You see this enlarged pulmonary artery here. So this is one of the things which you can see in the chest radiography. What else? You'll also see dilation of the right ventricle. There is, as I told you, there's hypertrophy and dilation of the right ventricle. See, look, this is your normal right ventricle. We mainly look at the cardiothoracic ratio. Okay, so, the ratio from here, just see this blue mark. This is the ratio, the thoracic ratio, and this is the cardiac ratio. From this end to this end is the cardiac, and from this end to this end is the thoracic. We take out the ratio, and this ratio, normal ratio, is 0.45 to 0.55. Okay, so look at this. See how much there is increase. Okay, so here there has been the dilation or the hypertrophy of the right ventricle. Okay, so when we take out this ratio will come out to be more than 0.55. So there is enlargement of this cardiothoracic ratio. So these are the findings which you can find. You'll find enlargement of the pulmonary artery. You'll find, the ventricular dilation. So these are the things which you can find in the chest radiography. Okay. Next, what are we going to do? We are going to go for the ECG. Okay. Next, we are going to go for the ECG. Okay. So what are you going to find in the ECG? You will find features of right atrial enlargement or right ventricular enlargement, and you'll also find a right axis deviation in certain cases. Okay. So how will you find out right ventricular hypertrophy? You'll have to look at this R. Can you see this R wave? V1. This is your lead V1. Look at this R wave and lead V1. This is your R wave. R wave. Okay. So if you see a normal ECG, you will find in V1. usually the S wave is more prominent. R wave is not very much prominent. S wave is prominent. But if the R is to S ratio, it is more than 1. Means the R wave, this is more prominent in V1. Okay. And okay, so we mainly, although there are many other criteria of right ventricular hypertrophy also, but just normally I'm just telling you. So mainly the R by S ratio, R is to S ratio, and the lead V1 will be more than 1, right? And or this R wave in the lead V1, if it is more than 7 millimeters. Already I have discussed with you the basics of ECG. You can go there and you can see how to measure, how to measure these, what's time seconds and what is all these things. You can just go there. I have demonstrated the normal ones and the the ones that have told you details how to determine right ventricular hypertrophy and all. So if it is more than 7 millimeters, the R wave or this R is to S ratio in the lead V1, okay, so that is more than 1. This goes more in favor of your right ventricular hypertrophy. And how will you see the right axis deviation? What do you remember from the class on ECG which I had taken? Which two leads we mainly see to determine the right axis deviation? Or any axis deviation, left axis, right axis, indeterminate axis, whatever. So which is the two leads we see? Mainly 1 and lead AVF. So what can you see? What is the, in lead 1, is it negative or positive? Lead 1 is negative, lead AVF is positive. Again, this is going more again in favor of right axis deviation. So these are certain X-ray findings, ECG findings, which you can see. Okay. And what else will you do? After this, if you find these changes, after finding these changes, what else are you going to for the echocardiography? Okay, so you are going to go for the echocardiography. In the echocardiography, you can clearly see, the ventricles, hypertrophy of the ventricles, and you can see the elevated pulmonary systolic pressure by using the Doppler echocardiography. So these things you can see. Then we'll go for the BNP test, brain natriuretic peptide. Okay, so this is also a very useful marker for the for the biomarker for pulmonary hypertension in the patients of COPD. If this patient has got COPD, to determine whether there is a pulmonary hypertension in these patients or not, we can see the levels of BNP, brain natriuretic peptide. And for pulmonary embolism, if we are doubt that the patient has developed pulmonary embolism, we can go for a ventilation perfusion scan. In this, we mainly see the ventilation and the perfusion, in the lungs, the ventilation perfusion scan, right? What else? You can also go for a CT pulmonary angiography. I think I have got a picture of CT pulmonary angiography here. Yes, look, this is how a CT pulmonary, you can see the entire pulmonary tree. This is visible here. Okay, so this is a picture of your CT pulmonary angiography. So in CT pulmonary angiography for acute pulmonary embolism, you can go for a CT pulmonary angiography. So these are the different investigations which we do. Next is, how are you going to manage this case? So management of chronic cor pulmonale. First, we go for the general measures. What are the general measures? We obviously start the treatment to decrease the pulmonary hypertension, because here the main cause is the pulmonary hypertension. So first we'll try to decrease the pulmonary hypertension. And what is the most important treatment for reducing? We'll come to the drugs, but before that, which is the most important treatment for decreasing pulmonary hypertension? Oxygen therapy. Yes, oxygen therapy is in fact the most important treatment to reduce pulmonary hypertension. Long-term oxygen therapy. This is the only treatment which reduces the retard of this pulmonary, which retards the progression of pulmonary hypertension. Okay, chronic oxygen therapy, and it should be administered in a controlled manner so that we maintain the level of PaO2 around 65 or 60 millimeters of mercury. Okay, so you must have seen COPD patients, they always roam about, wherever they go, they carry an oxygen cylinder with them, isn't it? So COPD patients are usually, we advise them that to take oxygen for at least 12 to 15 hours a day. So this is one of the most important treatment to decrease the pulmonary hypertension. And if the patient has developed, right heart failure, what is the treatment of right heart failure? General measures first we are talking about. Then I shall talk to you about the additional measures. General measures, what else? Salt restriction, digoxin. If the patient has, along with the heart failure, if the patient has also got atrial fibrillation, right heart failure, along with right heart failure, if the patient has got atrial fibrillation, the patient can take digoxin, diuretics. Okay. So what else can be done? First, talking about the general measures. First, I told you the patient has to restrict salt. Okay. Then next, what did I say you? I told you about digoxin. If there is a atrial fibrillation, along with heart failure, if there is atrial fibrillation, then come to the diuretics. Okay. And if the hematocrit, if the blood, if there is hyperviscosity, if the hematocrit, it is more than 60%. Hematocrit, if it is more than 60%. Okay, so in case if the hematocrit is high, in these cases, when if the hematocrit, this hyperviscosity, okay, so if the hematocrit is high more than 60%, we carry out phlebotomy. What is phlebotomy? Phlebotomy, it means, usually a puncture is made in the vein, usually in the arm with a cannula, and from there the blood is withdrawn. Okay, this procedure is also called as letting out of blood. Okay, so the puncture is made in the vein and the blood is withdrawn. So don't get confused between phlebectomy and phlebotomy. Phlebectomy is, removal of a vein, and phlebotomy is making a puncture in the vein to draw out the blood. Okay, so this is done if the hematocrit is more. What else will you do? You can also give vasodilators to reduce afterload. This is beneficial, but only for a short period. They lack effectiveness long term. The next therapy, let us come, then we are gradually coming to the drugs. I'll just write down the names of the drugs. First is the vasodilators. Okay, then you have got your prostacyclin analogs. Okay, then you have got sildenafil. Then you have got bosentan. Okay, so let us look at the vasodilators. So vasodilators, mainly we use which vasodilators? The one which is going to decrease the afterload. If you do remember, I had told you in the very beginning, that vasodilators, not in this lecture, in the previous lectures, that vasodilators can be the venous vasodilators or the arterial vasodilators. So here, which type of vasodilator are we going to use? Yeah, yes, obviously here there is pulmonary hypertension. Okay, so there is a increased pressure in the pulmonary arteries. So here we mainly give the arterial vasodilators, arterial dilators. Okay, so arterial dilators, like you have got your drugs like hydralazine, nifedipine, nifedipine. Remember nifedipine? It was a calcium channel blocker. So hydralazine, nifedipine, but these are not recommended because there are some side effects of these also. So they are beneficial only if they are given for short time for reducing the afterload. Next, come to the prostacyclin analogs. Again, prostacyclin analogs, they have not been studied thoroughly. There are not much studies, studies in them in Cor Pulmonale, which is secondary to lung diseases. But, prostacyclin analogs like epoprostenol, treprostinil, they are used in the treatment of pulmonary hypertension, but much studies are not available on their efficacy, right? Okay. So how are these prostacyclin analogs going to work? Like, this epoprostenol, if you do remember from your earlier, from second year chapter, where you have studied about the prostaglandins. Prostaglandins, epoprostenol, this is a prostacyclin. Which prostacyclin is this? PGI2. And what does it cause? It causes the dilation of the blood vessels. Okay, so it causes dilation of the blood vessels. Therefore, we can use this epoprostenol for treatment of pulmonary hypertension. Although I'm telling you, much studies are not there on this. Then is sildenafil. How does the sildenafil work? It is a phosphodiesterase inhibitor. Okay, so this is a PDE4 inhibitor. So what it does, it increases the concentration of cyclic GMP. And the cyclic GMP, again, this also causes dilation of the blood vessels. Okay, and this has also been used in the treatment of pulmonary hypertension, but again with variable results, not very consistent results. Then talking about bosentan. What is bosentan? Bosentan, this is the endothelin receptor inhibitor. Endothelins, they cause vasoconstriction. So if we give an endothelin 1 receptor blocker, so if we give a blocker of this endothelin, so again, this can also cause vasodilation. Okay, so bosentan, this has also been used for pulmonary hypertension. So these are the main drugs which we use for the treatment of pulmonary hypertension. Vasodilators, short-term, prostacyclin analogs like epoprostenol, sildenafil, and bosentan. right? Then what additional measures can you take in patients of COPD? In COPD patients, like if they are smoking tobacco and all, you tell them, avoid taking tobacco, and, avoid cigarette smoking. Cigarette smoking is the most important reason of COPD. If there is too much of secretions, too much of mucus, usually in the bronchitis patients. So to do bronchial toileting, what we do the bronchial toileting in the patients of bronchitis. And if the patient along with the COPD, often what happens in COPD, there is obstruction of these airways. These airways, they get filled up with mucus, and there is obstruction of the airways, and often the patients of COPD, they develop respiratory tract infection. So we'll just see whether the patient has developed respiratory tract infection or not. In those cases, we are going to treat them with antibiotics. Okay, and if the patient is having difficulty in breathing, we can also give the patient bronchodilators. We had studied in the bronchodilator chapter that anticholinergics, they are the most common bronchodilators, ipratropium, tiotropium bromide, which are given in the patients of COPD. And even the patient has come to you with bronchospasm, you can give the patient corticosteroids. Okay. And this is about all the treatment. I told you the general measures. I told you the drugs. These are the additional measures. These are the additional measures. Respiratory infection, give antibiotics, bronchodilators, corticosteroids. These are the additional measures which you are going to do. And last, let us come to the surgical treatment. What is the surgical treatment you are going to do? If the patient has got pulmonary embolus and if it is unresolved, then what will you do? You will do pulmonary embolectomy. So you'll remove the embolus by surgical means. Pulmonary embolectomy. Okay, and again, in those patients with primary pulmonary hypertension, you can go for the heart-lung transplantation, or if the patient has got interstitial lung disease, okay, so then that particular lung, okay, so you can go for a lung transplantation. The lung which is affected, you can go for a unilateral lung transplantation. So these are some of the surgical things which you can do. Heart-lung transplantation, okay, unilateral lung transplantation. So this is all about it. So I'll just repeat to you once more. So what did we study till now? I told you about cor pulmonale. Cor pulmonale is right heart failure, which is mainly due to the causes diseases in the lungs, pulmonary circulation or thorax, not due to left ventricular failure. And the types are mainly of two types: acute cor pulmonale, chronic cor pulmonale. Acute cor pulmonale, the most common reason of acute cor pulmonale is a massive pulmonary embolism. And chronic cor pulmonale, it can be of different causes, which can lead to destruction of the lungs, or there is hypoxia, or there is any sort of obliteration in the lung vasculature. So most common cause of chronic cor pulmonale is COPD. Right, then I told you about the clinical features of acute cor pulmonale. Acute cor pulmonale, it will have all the features as you can see in a patient of pulmonary embolism: dyspnea, hemoptysis, tachypnea, chest pain. And the patient will also have raised JVP, parasternal heave, okay, right S3, gallop, okay, so all these things. And then coming to the chronic cor pulmonale, as I told you, the causes: COPD, pulmonary tuberculosis, interstitial lung disease, cystic fibrosis, pleural fibrosis, or there can be repeated, recurrent pulmonary thromboembolism, primary pulmonary hypertension, collagen vascular diseases, or there can be some diseases of the thorax like kyphoscoliosis, neuromuscular diseases, obesity, sleep apnea syndrome. So these are the different diseases of the thorax. Okay, and then I told you the pathogenesis, how hypoxia is causing the constriction of the pulmonary vasculature, that is increasing the pressure in the pulmonary arteries. It is causing dilation and hypertrophy of the right ventricle, and it is causing right ventricular heart failure. Okay, so what are the symptoms? What are the clinical features of the patients of chronic cor pulmonale? Symptoms, how the patient will present to you: the patient is having dyspnea, it is not relieved even at rest, there is swelling of his feet, okay, and whenever the patient is doing exercise, there is breathlessness, there is cyanosis, the patient is developing bluish discoloration of the skin, there is dry cough, fatigue. And when you are going to examine the patient, you'll examine for the JVP, you'll find a raised JVP, you'll find swelling in his legs, pedal edema in the feet swelling in the feet, pedal edema. And when you place your heel of the hand on the left parasternal region, you can find an uplift or a thrust, which is called as parasternal heave. Then when you auscultate the chest, you will find a loud P2. Okay, so the loud pulmonary component, there is a pulmonary ejection sound. You can also find the ejection systolic murmur. And if the pressures are increased a lot, if there is very high pulmonary artery pressure, you can also hear a pansystolic murmur. right? And overt right heart failure, you will find all the features of right heart failure. You'll find raised JVP, tender hepatomegaly. Okay, you'll find cardiac enlargement. There is peripheral edema. There is peripheral congestion, systemic congestion. Okay. And what investigations will you do? I showed you the investigations also, what all features were there: chest X-ray, ECG, echocardiography, BNP, okay, and ventilation perfusion scan, and CT pulmonary angiography. What are the measures? Management, first general measures. I told you now how the treatment, two things we have to do. First, treatment to decrease the pulmonary hypertension, and treatment of right heart failure. So to decrease the pulmonary hypertension, most important, oxygen therapy, 12 to 15 hours a day. And right heart failure, salt restriction, digoxin, diuretics, vasodilators, very specifically, if you want to control this pulmonary hypertension, drugs used for controlling pulmonary hypertension. I had told you those 4 drugs, remember? Vasodilators, prostacyclin analogs, and you have got your bosentan and sildenafil. Surgical treatment, first, obviously, you write the general. Additional, in additional, you can write about like COPD patients, what else you can give? Like you can do bronchial toileting, you can give corticosteroids, you can give bronchodilators, you can give antibiotics, and still not relieved, surgical treatment, go for transplantation, heart lung transplantation, unilateral lung transplantation. Okay, if there is massive pulmonary embolus which is unresolved, do pulmonary embolectomy. Okay, so this is all about the case of chronic and acute cor pulmonale.